The next session is State-of-the-Art Lecture. The moderators are Professor Masao Omata and Professor Shinichiro Shina.
So the first session is I will do the moderations, and then speaker is Shibsarin, and probably I don't need introductions. The reason is I've known him for many, many years, but just about 2 months ago I went to his hospitals, and the operation is maybe one of the best and one of the biggest hospitals, ILBS. So I think he has now accumulating so much of the experiences in the hepatology area. And today, I think he will talk about those matters in the past and also the future. So Dr. Shibsarin, please.
Thank you, Professor Omata, for your kind words. And your visit to us was a big stimulus at ILBS. This talk is relatively new and will give some ideas to people how the field is moving on ACLF reversibility and improving survival. I have nothing to disclose except to say most of the work is done by the ARC team, APSL, ACLF Research Consortium, supported mainly by Ashok, Vinod, and Manoj, and many other members. ILBS have brighter residents and brighter faculty than me. The definitions have been challenging, and I will show you what new work has been done. The main difference is Apostle uses a hepatic insult with a bilirubin of 5 or above with coagulopathy within 4 weeks with ascites and or HE in a patient with cirrhosis or chronic liver disease with high mortality to identify a select group of patients, while the West, Cliff and Easel, they identify any insult, any, for 4 to 12 weeks, and this can have any inciting event, any. More than or equal to 2 extrahepatic organ failures includes decompensated cirrhosis, SIRS infections, and more importantly, jaundice is not necessary. The Japanese, I'm very happy and proud to feel, define ACLF like Apostle, a deterioration of liver function in cirrhosis with a child Pew between 5 to 9. They exclude decompensated. They use bilirubin of 5 and above, and INR of 1.5 and above with high mortality in 28 days. So this is almost akin to Apostle. The Mexican Association of Hepatology has also defined that ACLF is a potentially reversible syndrome with acute hepatic decompensation resulting in liver failure, that is jaundice and coagulopathy. So let me now put it in perspective. A patient who has decompensated cirrhosis, he gets further decompensation, and then this results into sepsis, shock, bleed, AKI, HE or organ failure. Or there is a patient who has advanced fibrosis F3, F4, or has cirrhosis of the liver, and he gets decompensated with an acute insult which results specifically in liver failure with a bilirubin of 5 or above, INR of more than 1.5 with ascites. So this is a decompensation in addition to liver failure, and this is just one phenotype. But if you use other types like bleeds, HE, ascites, AKI, sepsis, these are normal complications, natural history of cirrhosis. So you may end up having 27 phenotypes if you use the Easel-Cliff definition. And more importantly, Baveno 7, and I'll come to it, has what is further decompensation. These are new areas. So I once more want to repeat that if you have a patient with chronic pancreatitis and he gets infection, you don't call it acute on chronic pancreatitis. Then why do you call a patient with cirrhosis who gets a pneumonia as acute on chronic liver failure. So to have clear therapies, we must have clear inclusion criteria. Now this is further decompensation. Please pay attention. This is a prognostic stage associated with higher mortality than first decompensation, and it is driven by ascites, variceal bleed, hemorrhage or HE, and or jaundice, and development of recurrent events, and it can be in bleeders, it can be ascites, HE. So there was one decompensation, and then in the decompensated, second decompensation occurs. So how can further decompensation be different than ACLF? You need to see. Now let's see this paper again by Jonah Tribeca. Now patients had grade 2 ascites, they got SBP, HRS, variceal bleed, they got further decompensation. This is further decompensation, then there is a third decompensation. Will each of these events be ACLF? Or this is the natural history in which 40% would die because cirrhotics will die due to a terminal acute event. So we need to decide, should we call all these as ACLF or a natural history of cirrhosis? So let me come back to what we feel is ACLF, and that is a patient has an acute insult either by alcohol, HBV reactivation, viral hep, autoimmune hepatitis, drug-induced liver injury, Wilson flare, or sometimes we can't find out. And this results into liver failure, which is a jaundice, coagulopathy, ascites with or without HE. In a patient who has got underlying cirrhosis or CLD, but there is a reversibility factor, but also there is high short-term mortality. So let's hope it is clear what is ACLF. So while Easel and Cliff will give you a heterogeneous phenotype and require an extrahepatic organ failure for diagnosis, Apostle Arc gives you a clear phenotype. But we can't live with two definitions. We have to make attempts to converge. So this paper, which is now in press, we have tried to see how can we put all these definitions in perspective. This is pre-ACLF according to Easel and others. In this, you have bilirubin of less than 5, INR of less than 1.5. Is this pre-ACLF or it is just simple jaundice in a cirrhosis? Then you have what Apostle defines, and then you have Easel where it is more than 12. And then you have Nexelt, which defines with more organ failures. So bilirubin level and the organ failures are in a journey. You pick up early or you pick up late when you can't do much. So this is what we feel can be improvement in our definition. Means liver failure is the core. Then you have patients who have got ascites and or HE. They have a high short-term mortality. There can be a underlying chronic liver disease, and this is reversible. Yes, the current Apostle definition does not have organ failure and the definition, and it is only in prognostication. But one can think of whether we can add an organ failure other than liver. But liver is the core which leads to other organ failure. So we can redefine ACLF once the debate is on. Or there is a simple way of defining. This is now type A ACLF or type B ACLF rather than West and East. Type A ACLF is Apostle in Japanese, where you use the ARC score and you can have A1, A2, A3. I'll come to it. These are the grades of liver failure. Or you can have type B ACLF, which is Easel, Cliff, Nexelt or Koch, where you have grading based on organ failures. So a patient comes, you can say it's type A ACLF, type B ACLF, and people can understand. This is the reason we have made this concept diagram. Having defined and trying to make some inroads into convergence, let's go into the concept of reversibility. It's a brand new concept, but was seeded in 2019. 2019, we defined reversibility at day 90. And what is reversible is the defining criteria are reversed, means bilirubin has come to less than 5 or coagulopathy has reversed and there is no HE with or without resolution of ascites. And such patients tend to have better outcome. Now we have analysis of data to show you what is reversibility. But before that, what are the targets to make reversibility possible? So this is the pathogenesis concept of ACLF. You have from gut bacteria come, a leaky gut, it causes inflammation. On an insult which is due to alcohol, virus, drugs and others. So there is cell death, there is also a leaky gut. This will lead to activation of stellate cells, Kupffer cells and the whole cascade of sensors into the liver. And these sensors will lead to mediators like cytokines which go and the cycle goes on. So the mediators are there which can lead to organ failure and also development of sepsis. So our targets could be, we can remove this, we can eliminate the acute insult, we can reduce the cytokines and we can work to prevent organ failure. So this data of about 8,600 patients from ARC registry, the largest registry of any liver disease globally, we have patients 24% died by day 7, about 37% died by 15 and 46% by day 30. Now reversibility was achieved where both bilirubin and INR came down in just about 6% or so. Bilirubin alone 9.3%, INR alone 7.3%, or either bilirubin or INR in about 11%. To put it in perspective, reversibility is still not achieved. We are still picking up patients too late, even if we use a partial definition. With this data in mind, we have to work more to refine, may include pre-ACLF. What are the parameters which differentiated reversibility versus no reversibility? Everything, BMI, heart rate, hemoglobin lower, more of white counts, neutrophils, platelets being lower, urea lower, maybe something to be seen, serum creatinine higher, and sodium lower, and bilirubin levels being higher. Also, they had lower albumins, more INR, more ferritin, probably not different. CTP levels were higher, and MELD was higher, and ARC score was higher, and lactate was high. And also, HVPG was not different. So, we used to believe HVPG can determine, but not. But yes, you have other parameters which can say reversibility. Based on this, Predictors, a multivariate analysis was done, and finally BMI, white cells, albumin, platelet counts, and ARC score were the major determinants. And we were able to find out a new formula for finding out which patients. So if you use these 5 variables, you will be able to say with certainty in about 70% plus. Here you can see, 93% plus, you would be able to say this patient will reverse or will not. An interesting finding which is not included, patients who have a high AFP did well. There was earlier a term called impaired regeneration syndrome for ACLF. And this term was used by a very important Japanese group where they were saying the ACLF means cells do not regenerate. So high AFP is a good marker of regeneration. Using this, we were able to find out also that ARC score predicts very reliably 94%. So ARC above 11, chances of reversibility are low. So it once more emphasizes the beauty of ARC score. Now, when we looked into etiology, alcohol and stopping alcohol is amongst the best. Treating Hep B, removing the drug, these are the major reasons for reversibility also. Do patients with ACLF get again an attack? And this is ACLF again. not further decompensation. ACLF again can be seen in about 14% of the patients. Some of them are due to ascites reappears, or these patients will bleed. So both are complications of portal hypertension, which if managed well, we can improve the reversibility and survival in these patients. So to answer, is ACLF reversible? Yes, in a small proportion. What we can do to achieve more of reversibility? So douse the acute insult. This paper showed that those patients of hepatitis B and reactivation, if the DNA levels could be brought down by more than 2 logs in 2 weeks, majority will survive. But if DNA does not come down, they die. It is because of the massive HBV replication in these patients. In severe alcohol-associated hepatitis, where there is liver failure, ascites, and jaundice, we would see, and I showed this in the morning also, that only 30% or so are steroid eligible out of this large number. Those who are eligible, only 44% respond to steroids. So just about 12% or so will be responsive to steroids. 88% we need to find other modalities. Who will respond? Those people who have an ARC score of less than 10, they have better responsiveness. If ARC goes above 10, steroid non-responsiveness. Also, ARC above 10, you have high mortality in this. So, cutoff of ARC of 10 predicts at baseline steroid responsiveness and survival. Now, what is this ARC score? One more time, just to say we have 4 liver-related parameters: bilirubin, HE, INR, and lactate, and 1 kidney-related parameter. And this gives you ARC grade 1, 2, and 3. If patient has ARC 3, then the chances that he will not survive and will not respond to steroids are very clear. There is another good model using hepatitis B called Tongzi model, and the Tongzi model by Dr. Kin Ninching is also a very useful model. If the patient is not responding to steroids, can you do something more? Yes. These patients can be given fecal microbial transplant, and this microbiota transplant, when compared with the steroids, gave an added advantage. So it's as effective, maybe more than steroids, and it is safer. It does not give infections, decreases gut permeation, and modulates mate cells. Can you reverse ACLF by reducing portal pressure? This study of acute portal hypertension will tell you in ACLF, due to cell death, lot of cytokines are released, stellate cells are activated, endothelial dysfunction, so there is no relaxation, and because of high bilirubin and bile acids, one of the major drivers of hyperdynamic circulation, there is a vasodilation and mean arterial pressure goes down. So a patient with cirrhosis who already has high portal pressure, let's say 12 or 15, when ACLF develops, there is a rapid rise in portal pressure, maybe from 12 to 18 or so. And this leads to development of ascites, hepatorenal syndrome, variceal bleed, and hepatic encephalopathy. So if you change this paradigm, if you try and reduce pressure enough in time, so in a large series of patients, 126, baseline HVPG was 15. Those who recovered, the pressure came down from 15 to 7. However, those who did not recover, in fact, they developed varices in 4 weeks. So pressure and recovery correlate. If the patient recovers, HVPG goes down. Here, the study which I will show you, patients who have got either carvedilol or placebo, any of them, those patients who reduce portal pressure, they survive much better. So it is not carvedilol alone, it is the natural history of the disease also. Let me show you here. Those who had less than 20% reduction in portal pressure, they had progression of varices. But those who have more than 20% reduction in pressure, either by beta blocker or by spontaneous method, in them varices did not form, only 10% or so. And then those who had carvedilol, significant reduction occurred in portal pressure, and also there was a distinct survival benefit, 89% versus 75%. So I think reduction in portal pressure helps. Furthermore, this helps in reduced development of AKI, new onset, or SBP, 6% versus 21%. So pressure determines organs to fail. So reversal of acute portal hypertension adds to ACLF reversibility, improves outcomes in ACLF. I hope you can take this message, try and reduce acute portal pressure. Now, can we have further improvement in survival? There is jaundice, but can you still stimulate liver regeneration? Can you achieve immunohomeostasis, or bioenergetics can be changed? Now, this is mesenchymal stem cell therapy, bone marrow derived. It has been shown to improve survival in this study in hepatology. Standard medical therapy versus MSC therapy, there is a distinct advantage in survival. When this has been put into perspectives, the bone marrow derived, umbilical cord derived, or other cells, then you find there is an advantage of giving stem cell therapy or mesenchymal. They ameliorate the cytokinemia, ongoing cell injury by stem cell therapy in these patients. So this is a good modality. But can you regenerate liver? Yes, GCSF can work on the bone marrows, mobilize CD34, 133 positive cells, and these cells can help into maturation, differentiation of hepatocytes. Also, progenitors are mobilized and they can help in liver regeneration. So in this study, about a decade ago, we showed GCSF mobilizes these cells and improves outcome. Here, underlying already there is liver regeneration. About 30% of the cells, CD34 cells, were seen here. But once GCSF was given, you can see all these brown staining. There are almost 70%, more than 2 times increase into the CD34, 133 positive cells. And this also led to improvement in the survival. Hence, liver can regenerate despite ongoing liver injury. GCSF has also been tried by other centers. They have shown that GCSF compared to control in alcoholic hepatitis can improve survival, and also GCSF when combined with N-acetylcysteine can be superior with GCSF plus GCSF therapy versus standard therapy. However, this data has not been reproduced in the West. This is the data from Asia, which all favors GCSF, but in the Europe, it has not favored. And the reason could be they have not used patients who have got jaundice. They have used decompensated cirrhosis, sarcopenic. 54% of them already at baseline had sepsis. So maybe the choice of patients is the determinant of the outcome of GCSF. Infections. First, there is cell death, intense inflammation, loss of the surface markers on dendritic cells, neutrophils, or other antigen-presenting cells. This leads to sepsis. The first SIRS, then sepsis, and this is because of impaired functions of your immune cells. Now here, a patient with cirrhosis, compensated liver disease, gets an acute insult, gets ACLF. Now his neutrophils are non-functional, so he gets sepsis, and post-sepsis he gets liver failure, renal failure, HE, and other things. However, if you give GCSF, there is an improved dendritic cell neutrophil function, and you can restore this function and prevent sepsis. This is the reason that you can regenerate both the liver as well as prevent sepsis. You can also use some bridge therapies like plasma exchange. sorry, we lost the plasma exchange can be used. In this meta-analysis, 30 days, 90 days mortality was reduced. It favors plasma exchange. What plasma exchange does is removes the cytokines, it removes the toxins and allows the liver to regenerate. So metabolic functions. Now this is a very important and interesting slide and we use it. Now here are patients who are responders or non-responders to plasma exchange. This is OCR, is oxygen consumption rate of monocytes. So while the patient is on plasma, you take out these cells. So oxygen consumption rate, which is a marker of the capacity of your monocytes, in non-responders does not change with plasma exchange. He is a non-responder to plasma exchange. While a responder, his oxygen consumption rate improves. So now this is a viable, robust monocyte. So plasma exchange can restore your immune functions. This paper just tells you there are three modalities. One is standard medical therapy, one is plasma exchange, and one is heme adsorption. There are so many toxins and metabolites which are there. When you give plasma exchange, most of them can be reduced and heme adsorption further helps. Here you can see that plasma exchange versus heme adsorption, much more reduction in the metabolites. And here you can see that using heme adsorption, you have much better at day 7, organ failure is least, with plasma exchange is still there, and day 14. So maybe adsorption of metabolites could be a good way. This slide shows you whether you use single mono artificial liver support. It can be one of the plasma exchange or heme adsorption, or you use multiple artificial liver supports. So if you use multiple artificial liver support, you reduce bilirubin, you reduce bile acid, HRS improves, and here you can see multiple modalities versus single modality, multiple is better. So now we are moving towards combining plasma exchange with heme adsorption as modalities of therapy. Can we give a predictor? And this is also a very new data to show you. Patients with ACLF, they have more of 11 beta hydroxylase and cortisol levels, but the conversion of ACTH to cortisol is inhibited, and 11 deoxycortisone increases, and the feedback loop is inhibited. So patients have very high levels of 11 deoxycorticosteroid. So such patients will not respond to steroid. They are actually they are failures because of corticoid receptor failure. So if these levels are high, these patients are likely to die. There is another new device which is Dialiv. Dialiv has a concept that patients who have got ACLF, in them albumin and the toxins can be taken out, endotoxins can be absorbed, and at the final destination, fresh new albumin is given. This albumin is toxic. However, once this was given, it gave you early resolution but no survival benefit. To summarize, in ACLF, medical treatment in 2024, we can use statins to prevent development of ACLF. We remove the insult. Also, we would see that ARC less than 10 or 10 is used with steroids. We give good nutrition of 35 to 40 kilocalories. Reduce the portal pressure. We can use preemptive tips. Do not do large volume paracentesis because they have high plasma renin. We can start terlipressin early rather than wait for long. And we can give Norflox or antibiotics or GCSF. If the patient has HE, lactulose, Pegleg, prefer NIV. If you intubate these patients, their chances of recovery are less. Correct coagulopathy, give crystalloids, and maybe plasma exchange can be done with caution. Liver transplant is the final savior. Well, the way forward is proper selection. Now here in this study, it was shown that patients, when they come to us in emergency, only 34% are eligible. But in 4 or 5 days' time, you can make them eligible. So in your intensive care, medical manage, if it is good, you can improve. And this is the transplant window of day 7. If you go beyond it, it may not be beneficial. And these are cases who are probably futile transplant, GI bleed, untreated sepsis, and infections which are not treatable, pulmonary PaO2, FiO2, high NORAD, high lactate, 3 organ failures, and survival is then less than 50% at 5 years. I would like to say, when a patient of ACLF comes to you, try and treat etiology, try and do ARC score or a MELD, control sepsis, give nutrition, prevent HE, and plan transplant if patient comes on day 0 with a score above 10. But if he improves by day 4 with your efforts, you may actually try and continue with medical therapy in them. But if it is worsening, you need an emergency transplant. If the patient using CLIF and other definition already has 2 organ failure, you might need exchange, plasma exchange or artificial liver support, stabilize this patient, and maybe then emergency transplant. But if he is not improving or has more than 4 or more organ failures or ARC is above 13, it's a futile exercise. I hope we can make our patients survive longer. And I also want to invite you on behalf of Apostle for the next meeting in 2025 in Beijing. Thank you for your kind attention.
Thank you very much, Shiv Sarin. I've known him right after he graduated All India Institute, AIMS. AIMS is famous, very top-notch university, but he right away went into the GB Panda Downtown Hospital because he wanted to take care of the patient as a whole. Today's story is all about the whole, not just liver limited. You have to manage everything, liquid, everything. So I think I have known Shiv Sarin for such a long time, but today's it's a little bit of a summary, but this is still in the midway. You got to go further away. So I hope you keep continuing like that. Thank you very much.
Thank you.
Thank you very much, Professor Sarin and Professor Omata. This concludes the first part of the State of the Art lecture. The moderator for the second part is Professor Shuichiro Shina. Professor Shina, please start when you're ready.
So now it's the last session of today. Today's last session, and so I'd like to introduce Professor Weilai. He will host the APASTHROUGH 2025 Beijing, and today he will talk about the MAFLD. The lecture of his is titled "Should Be Digital Pathology in MAFLD Now?" Professor Lai, please.
And thank you, Professor Sherna. Thanks for your very kind invitation to be here, and also thanks for your kind introduction, and congratulations for very successful Apostle, and again in Kyoto. And so, your distinguished and Professor Omata, Professor Sarin, and also ladies and gentlemen, and good evening. Okay, my topic on state of the art is the digital pathology in MASH clinical trial, and this is my disclosure. And NASH has become the leading cause of liver cirrhosis and liver transplantation in recent years, particularly in United States. and also only a minority of the patients with the last LAFD develop an end-stage liver disease. So therefore, what's the major cause for the last and final endpoint and the clinical outcome? Then you can find the first cause of death in NAFLD or NASH population is cardiovascular disease. And the second one is the hepatic malignancies. And of course, and as the liver disease, the third one is complications of cirrhosis. And so, and what is associated for all these long-term clinical outcome? And some study already suggested the fibrosis stage is the only independent predictor of liver-related mortality. And here, I would like to show you two pictures. In the right, you can find in the 209 patients and the follow-up for the study and the follow-up that you can find in the last one is the dependent on the NAS score, particular for fibrosis. In the right one, you can find it, and the different in the NASH evaluation or non-NASH with the different and fibrosis. That is the non-NASH fibrosis none, and the non-NASH fibrosis positive, and the NASH fibrosis no, and the NASH fibrosis is positive. Then you can find the what is the important, what is the severe is the red curve. That is the patients, NASH patients with the fibrosis. So therefore, and it seems we can conclude fibrosis stage is the only independent predictor of liver-related mortality. So how about other long-term clinical outcome? In this very end study, very important study, and totally is the 17 and 73 patients follow up and 4 years. Then look at the different endpoint at the different end of the picture. In this one is death from any other cause. It's the all-cause mortality. Then you can find the significant fibrosis and indicated by the origin curve. And also in this hepatic decompensated and the clinical outcome. Also is the orangular curve. In this one is the hepatocellular carcinoma as well as for the actual hepatic cancer. So therefore fibrosis related to the all is a severe clinical outcome. Therefore, recently, last year, AASD and released a new guideline. Then in this guideline, to particularly mention how to evaluate fibrosis. And in this guideline, you can find the role and the interpretation of the liver biopsy. It is said histological evaluation of LAFD should provide the 3 basic pieces of the inflammation diagnosis, grading of the localizing inflammation activity, and the staging of fibrosis severity. So therefore, biopsy remains the best method for providing information on the architecture and distortion and the complex anatomic interrelationship of cellular injury, inflammation, and fibrosis. And also, in this guide, it mentioned image analyzed by artificial intelligence can provide more and granular detail of histological findings, as well as quantification of features on continuous scale, rather than the semi-quantitative score system available in human observers. Therefore, you can find here the this statement cited 2 references. I will share with you later. So evaluation of steatosis and fibrosis are the most developed of the AI algorithm. It says steatosis and fibrosis. And because of the physio and the co-chemical and the properties of lipid droplets and the collagen LOS for easily identification by machine. Then the inherent variability in the composition or character of the label and the portal inflammation, as well as the spectrum of the hepatocyte injury that is to identify the ballooning presents more and challenging in correct classification of quantification by AI algorithm, but is under development. So why they use that and what we can do? Actually, the NIST guideline and cited in the previous study published in 2020. The NIST paper and the so-called is the QFibs. The F indicated fibrosis, I indicated inflammation, B indicated ballooning, S indicated steatosis. So therefore, we developed the QFibs. It is the automatic technique to quantitate the evaluation fibrosis, inflammation, ballooning, and steatosis in patients with non-alcohol steatohepatitis. We, up to now, after published, it's already used in more than 22 phases. The phases 2B, a phase 3 MASH clinical trial in the United States and the European. Also, this technique used as a primary endpoint. It actually is the first in the digital pathology only study in phase 2B MASH clinical trials. And you can find here, I mentioned the NIST clinical trial, you can find it is only an indicator for the primary endpoint. So, how to understand? Let's go back to the fibrosis and regression and for all progression. And you can find, if we use the LASI-CRN score system, and we have some score based on some and the characteristics to report, to indicate the fibrosis progression. Meanwhile, something also show as a regression. They actually, and in these systems, is in the interact, is dynamic, and actually in same point. I mean same point and means the same time point. If you take the biopsy, maybe in some areas is the progression, and some areas like regression. Even in one neighbor, in different areas show a different and the characteristics, I mean the progression or regression. So therefore, in the progression and the regression is exacted at the same time, also is interacted. Then what we can ask for that? Usually, we calculate the areas of the pathogen. So therefore, in the pathologist give the evaluation and the score, and F2 or F3, they use the total profile, particular for the and the total and the collagen. So therefore, and sometimes you can find here in baseline F2, and at the end of treatment, it is still in the evaluated F2. You can find here is here. However, if we have the look at the detail, then you can find is some differences. So therefore, we we need more detailed analysis and a lot semi-quantitative for that. And so I means the collagen and is the basic for the fibrosis stage evaluation. However, the fibrosis stage does not always mean collagen and protein areas. If you look at here, you can find even some and the collagen is not and very in the distribution and very much. And however, even in some area, particularly in the portal or bridging, is still for the high evaluation for fibrosis. So therefore, in addition, I mentioned the last slide, we need more detail. Also, we need a more detail quantitative. Here, we need a more detail for location. So what and all technique and have the role and play anything. And here I want to take an example. And in this clinical trial, the trial is almost fair, but I don't want to talk the drug itself. I just want to, and the explanation of all technique, the Q-fibs, and how to work. You can find in here, for the placebo, and for this drug, and the low dose and high dose, you can find the significant differences is not obviously. And however, if you look at the detail, now firstly is the fibrosis score and from blind and paired read by pathologists. Then you can find in the regression after treatment and also the progression after treatment is the very and raw. And however, the most areas is the no change. And however, if we use the Q-fibs is the one technique and focus on fibrosis and from the Q-fibs, then you can find it's very effective, find in high dose population and much more the patients could be identified, could be assessed as the regression. So therefore, it's very effective. And also, if we use the Q-fibs as a continuous value, you can find here, and we can further improvement for needs evaluation. We can understand more for needs and the new drug in the effective in our patients. So actually, and this digital pathology with the artificial intelligence provide and great insight into treatment-induced fibrosis regression. What I mean, and I mentioned a few of the slides, that is that we need more detail in quantitative and in different fibrosis, and also we need more detail in the fibrosis location. And here you can find, and we can use this technique to evaluate the part tract area and also in the peripartal and also in the other areas, central vein, and also in the pericentral. So we can know in which areas and it has the severe and the fibrosis and all drug and play the role in which area. What is the importance? So, ladies and gentlemen, I will talk something for stent-free imaging or in the new technique that is based on second harmonic generation microscopy, and also will touch recent data in NICE clinical trial, and particularly about stratification of clinical trial design, use it as a primary endpoint. And of course, I will introduce additional value from AI, artificial intelligence, in digital pathology, and particular for the machine learning from current gold standards, and also above and beyond and the current gold standard. So what's the basic? What's the technique? The technique you know, and we also know the standard and the typically classic evaluation. We use the tissue after biopsy. We can cut this tissue, and also because we have used different and dyeing, and so give the stand for and the different slides. Then we invite pathologist to read. He will read the fibrosis stage, steatosis grading, hepatocyte ballooning, inflammation. So, however, using this technique, we developed the understanding. We used only one and the pieces. Then in this machine, and the AI help us to read and all and the parameters. And in particular, these parameters is and the focus on 4 parameter area. That is the Q fibrosis, Q steatosis, Q ballooning, and Q inflammation. Then, of course, it's a full and quantitative, no seminar quantitative. So it's a quantitative assessment. So what we can do, what we already do, firstly we use the training group, the sample and from the Singapore, China, and UK, the United States, and the French, and the Spain. And all these that we and the extract and the collagen parameters and totally parameters achieved 135. Then we also do something to analyze for the sequential feed selection and linear regression model in the pathological station. And also we select the parameters and also we confirm to use that and complete the training for the fibrosis models. So therefore, and finally, we can do the Q fibrosis. As the similar strategy, and we also do that, extract the parameters, and finally, and select parameters, and then, and the validation. So we develop Q fibrosis, that is quantitative fibrosis, and the quantitative steatosis, quantitative ballooning, and the quantitative inflammation. So you may ask, it works, you do, and too much. We just and have the new drug approved by United States FDA maybe 2 weeks in March 14. That drug is the resmetirom and produced by the Madrigal. And here we take example for the Madrigal resmetirom phase 2 and the study. In this phase 2 clinical trial, the samples, the biopsy was performed at the baseline of the treatment and the week and 36. Then you can find is an original and low significant for differences for and the dose and also between the drug and the placebo for fibrosis. They only find some differences for the steatosis. So the question is, if the really and low differences for fibrosis improvement or regression between the drug treatment population and the placebo population, as well as any difference between the high dose and the low dose resmetirom populations. So use this strategy, and we can find the clear, very clear statistical differences between the two comparisons. That means comparison between placebo and the resmetirom treated patients, and as well as no dose resmetirom and the high dose resmetirom. Here you can find the results. The blue color indicates the placebo arm. The red color indicates the resmetirom and arm, and in which the the column is the high dose population results, and no column is the low dose and patients. So therefore, because of this, you can find the difference for the whole population and all high dose population and 5-3 in the population. It seems the 5-3 population have the very significant high efficacy. So therefore, it's a suggestion turned out to be the new clinical trial design. They changed the primary endpoint for for phase 3 study to include and more phase 3 populations. It will be and provide more benefit to patients. Also, it will be give us more chance. And in addition to that, they still have some and the benefit implication for successful phase 3 program. Here, including the data from phase 2, screening criteria, histopathology reading, and particularly in the data from in the phase 3, it is said half of F3 patients and show more than 1 point improvement in fibrosis compared to the no placebo F3 patients who use NIS and the technology. So therefore, and it seems in the NIS and technology can help us to find which population could be and benefit from NIS drug. Therefore, of course, it's helpful for clinical trial design. So in the clinical practice, based on the lysis CRN systems, the fibrosis and the different has a different stage, have the different description. Anyway, this including portal fibrosis, periportal fibrosis, pericyloid fibrosis, bridging fibrosis, and cirrhosis. That is the lower. Anyway, you know the bridging fibrosis is very important because if we have the bridging fibrosis, will and develop to the cirrhosis. And meanwhile, actually, and the portal fibrosis and the periportal fibrosis is also important for the early stage populations because if very severe the portal fibrosis and the periportal fibrosis, maybe the patients will develop to hypertension, just as the Professor Sarin mentioned last talk. So, and therefore, in the real world, in the patients, the patients may be the changed for that. For example, the cirrhosis neurodevelopment may be from phase 3 to phase 4, or maybe others has a different dynamic change modeling. So how to understand, how to catch this pathology characteristics by our technique. And so we focus on 5 and the key parameters. We say it is a read and a map. In here, including portal and periportal, pericytoid, and the bridging and the pericentral vein. Then, for example, for this kind of the patients, you use the NIS biopsy sample. Then you give the NIS read evaluation. Then you can find this patient seems and the more severe pericytoid and the more severe periportal and fibrosis. And in the second one, you can find the patients with a severe bridging and fibrosis and also a little bit severe portal fibrosis. However, for the pericytoid and also pericentral, it's very and less and fibrosis. And meanwhile, for this one, and read by the green color, then you can find all are in the mild change. And then we give you the NIS and the lampers of the evaluation. Then you can find, for example, for NIS and the patients, the post-treatment and the patients, the bridging fibrosis still high and they score higher evaluation. So therefore, no significant improvement in bridging fibrosis. However, for this situation, you can find the pericytoid fibrosis is so high, even higher than this situation. However, the fibrosis is not so severe. So therefore, and we say that this different kind, the different situation, different characteristics of the fibrosis is also and connect to the final clinical outcome. Then here we go to back and the next study. The next study in the resmetirom, they reported the different stage of fibrosis. You can find indicated different color. The severe fibrosis will have the severe and long-term clinical outcome. And however, if you look at the detail, we used the evaluation on the drug and the thyroid and hormone and the receptor and beta, the activity. You can find the higher indicated by red color have the lower in the clinical outcome, no instance. And however, you look at this comparison, it's a low thyroid hormone receptor, beta receptor, is indicated by the blue color. The finally clinical outcome is higher. So therefore, this technique also can connect in the fibrosis and also this kind of receptor to give the evaluation for the long-term outcome. I mentioned that the different the characteristics. We have the portal and the central vein and parathyroid and the peri and portal. Here I give you the further analysis. Here then you can find the color change it. You can find here. So because the fibrosis is so important, we take out the steatosis. Just evaluation of fibrosis. You can evaluate in this different location of fibrosis, including portal, periportal, zone 2, and the pericentral and the central vein. Then you can find just pretty similar among these different areas, the location. And however, if we take out the steatosis, then you can find the very significant improvement for fibrosis in portal and periportal and zone 2, pretty higher compared with the pericentral and the central vein. So therefore, it's implied in this drug improve the fibrosis, maybe in the future, and reduce the portal hypertension. So ladies and gentlemen, I conclude here. Fibrosis changes is dynamic and the heterogeneous may be interacted. And the progression and the regression features exit at the same time. And progression path is different from the regression path. And also, current golden standard was not designed to record treatment efficacy. But because of this, we developed artificial intelligence to evaluate the liver pathology. And it already tells us it could be and provide potential solutions. Then particularly designed to record treatment efficacy and investigate treatment efficacy. Also validated with the clinical data, non-invasive test results, and biopsy. Finally, intuitive the visualization for interpretation of drug efficacy using AI and notation on the read map. So thank you for your kind attention, and also welcome to Apostle 2025 in Beijing. Thank you.
Thank you, Professor Wei. Now I can understand what is the digital pathology. Thank you very much. And so we'd like to close this session and today's final session, and we will go to the presidential dinner. Thank you very much.
Thank you.
Thank you very much, Professor Wei and Professor Shina. This concludes today's program in Room 1. Thank you for your participation.